Thank you for the elaborate presentation. Ladies and gentlemen, Assalamu alaikum. Good afternoon, everyone. I am one of the consultant gastroenterologists in Leeds, and I'm here to present about the optical diagnosis in ESD, seeing beyond the surface. I guess everyone sees my slide, right? Exactly, that was the question. So as endoscopists, what do? We throw some light on. So contrast enhancement does give you better understanding, better outlining of the lesions. So I'm glad people noted that it wasn't the right slide. It was because of the intention. Right, so let's start. So when we have issues, when we can't delineate the margin, what we do is we use virtual chromoendoscopy in any shape or form. For upper GI endoscopy, you have acetic acid for Barrett's examination, you have Lugol's for squamous examination, and for colorectum, you have various other dyes like methylene blue, you have indigo carmine, crystal violet if you are somewhere in Japan or in King's in London. So we do have various forms of dye-based and non-dye-based chromoendoscopy. It is important to use them because it helps in various forms. Number one, to delineate the margin. Number two, to characterize the lesion. And then decide about how we resect the lesion. So the most important thing is you cannot resect what you cannot define. That's the bottom line I think we need to understand. So the success of endoscopic resection is decided right even before the first cut. That is where it stands. That is where the diagnosis is. The diagnosis is really a battlefield, and that's where failures happen. If you don't do diagnosis precisely, you will end up having issues. The failures in endoscopy, endoscopic resections, are mainly at the diagnosis, not technical aspect. So there are 4 pillars, as you know: detect, characterize, define borders, and predict the depth. I think we have done really well in 2 of the 4 areas here. Detection, yes, really good, because we have got our eyes trained, we are training our juniors. We are doing much, much better in terms of identifying the lesion. Our rates of detection, adenoma detection, ADRs, have gone up over the period of time because of the awareness. And we also are somewhat good at defining borders because of the various image enhancement modalities, and thanks to various companies, the innovations of NBI has changed the way we practice our assessments. And these are the inventions that we should be proud about. But what we are not so good are on characterizing and also predicting the depth. With the help of AI, with the CADEX, we are better, we are getting there, I think. But we are not there in predicting the depth. I will tell you what I mean. So we've got various classifications to characterize a lesion. We've got for squamous dysplastic characterization, we've got IPCL classifications. You've got Kimura Takimoto for atrophic gastritis in the stomach. We've got Paris, JNet, Kudo, Sano. We've got various classifications. But do we use them accurately? Do we use them appropriately? And try and predict the depth is the question. So the examination starts when we insert the endoscope. That is where it all starts. So we have to be having an investigative mindset. That means we are the detectives, and we are going to find something in an upper endoscopy or a lower endoscopy. That's what the criteria should be. So this you can diagnose. You may not need to biopsy. You may need to send it to ENT surgeon. But you have diagnosed. You have actually identified the lesion. For squamous, remember, NBI helps you characterize, helps you define, helps you identify. So it does 3 of the things, and it may help you predict as well. Now this is staining is really important. Whether it is virtual, whether it is with your dye base, it is really important. On the one side, you can see the acetic acid stains, which are beautiful. It characterizes, it does not have any loss of aceto whitening. And on the other side, you've got narrowband imaging to show nice, beautiful borders. There is no pathology there in that slide, in both the slides. Whereas this does have problem. It does have loss of acetowhitening. That means some of the cells are not taking up the acetic acid, and those are the abnormal cells that you need to target for the biopsies. That is where the gold mine is. So spot the bad guy here. So what we do, we've got the adjuncts, we've got the cap, which is good, and we've got the good endoscope to look at the lesion. What we need is to zoom in. That's where you find the bad guys, and then you can characterize the lesion. And this is an example of Barrett's dysplastic segment. So this is a weird lesion which is slightly longer than what we normally usually find in the Barrett's dysplastic areas. So you then examine with white light, with narrowband imaging, and then you look for a loss of acetowhitening. You look for nodularity, anything within the Barrett's that has nodules or that has ulcerations, you need to treat it as abnormal or pathological intramucosal adenocarcinoma until proven otherwise. And then you can do the treatment. You can resect the lesion, and that is it. What about things that you can't see? What about the CWOT1, CWOT2 type of lesions? What about the lesions that are going into the cardia? It is really important that you retrovert, you identify the extent of the lesion, and then try and resect it. Once you have resected, this is where my most important point is, if you can focus on this particular area, there is crowding of the pits, and that is where your most abnormal part of the pathological specimen is. So that came back as completely removed from the histological analysis. So this is the most recent paper from Michael Berg's group, where they have looked at comparing the detection among the experts. This is important. This is detection among the experts to look at how we are doing comparing high-grade dysplasia to differentiating between T1 and T1A and T1B lesions. What it shows is among the experts there was good correspondences compared to when you're detecting high-grade dysplasia as opposed to T1A and T1B. That is understandable. We are really good at that. But what happens is when you look at differentiating between T1A and T1B, we are not so good. So that's what it says. That means we are still not predicting the depth of the invasion before even we consider resection. So T1B, identifying T1B lesion is better because you do have pathological hallmarks saying that this is actually shouting out like a cancer. That is fine. But whereas if you're trying to differentiate between T1A and T1B, no, we are not so good. What about squamous dysplasia? It is a different beast altogether. So you've got to be really, really careful because the classifications are very clear, B1, B2, B3 types of IPCLs. As it progresses from B1 to B3, the abnormality progresses. On the one hand side, you can see B1/B2, couple of B2 areas, but whereas in here, on this specimen here, there is absolute loss of characteristics within the cancer. This is barn door cancer. This is jumping out, it's nodular, it has lost its pattern, and whenever you see the pattern, they are type 3s. It's completely elongated and broadened. So that is squamous cancer. Choose the areas. You can do ESDs for a smaller areas to resect here, but this one should not be attempted. What about this guy? This is a really nice pickup on a diagnostic procedure. So this is a wide area of abnormal squamous mucosa with central slough. So then we moved on. I didn't to do a narrowband imaging. If you can see, focus on this area, everybody can focus this area here, right in the center. But what's happening in the north of this polyp is something which we need to focus on. Now look at that. There is complete denusion, there is avascular areas, and there is elongation of the pits. Another area, again, B3 type of pits. Now, that is the one which you should not be taking out. Now, the next case shows the importance of Lugol's assessment. So if you look at this area, with white light, narrowband imaging. Narrowband does highlight this area here with elongated pits. I don't know what's happening with this nodularity here. So we threw some Lugol's and we identified that area where a tiny, tiny area of pink sign, what we call as. That is where you need to focus on the biopsies. This is where the high-grade dysplasia / cancer is residing. Now, that's a close-up of that area. That is a barn door cancer until proven otherwise. Try not to resect this one. But whereas another sign of, another case of pink sign, which again shows that this should not be touched. So try not to do ESDs in these kind of areas. Lugol's is taken up nicely here. It's brightened up, but this area is completely pink. So that's a pink sign that you read. This is the cancer, this is the area which you should be targeting with ESD. This is homogeneous, there is no nodularity involved, and there are no ulcers, there are no abnormal IPCLs apart from B1s and / early B2s. So with the Lugol's, you've got nice and highlighted area, you can resect that area with ESD. So that's what it comes out as. Again, to highlight, when you resect the specimen, please spend some time assessing the lesion on the surface. Circumferential resections, yes, you can offer for squamous, but be very, very careful and choose the lesions appropriately. What about circumferential lesions, resections for adenocarcinoma? Again, you have to be very confident that there is no deep involvement here, and you can offer circumferential resections. This was about 8 centimeter resection, and as you can see, narrowband imaging highlights those avascular areas, but fortunately, this is the histopathological analysis, and it was widespread intramucosal adenocarcinoma along with high-grade dysplasias throughout that segment, but nothing deeper, which is actually quite good, and that's a complete resection. This is one of the most challenging ESDs I've ever done, and probably my heart was beating out of my chest. This was a supraglottic cancer, which was recurred, and ENT surgeons had tried, and they had asked me to do an ESD. So the major complication here is carotid blowout, and if you do that, you may not be able to save the patient. Although the tiniest ESD that I've done, but the most challenging case. Now is the quiz time for colorectal work. So these are the 3 specimens that I have removed, and I want your audience participation here. So the first case, this case here, was ESD. The second case was EID. The third case was freehand full thickness resection. So could you predict the histology in any of these and tell me which one I went wrong? So this one ESD, this is EID, and this is freehand full thickness resection. So on the right-hand side, I went wrong. Okay. Sorry? The ESD I went wrong? Middle one. Okay. Now, let's go into details. So that was the first case, which we did an ESD. The intention was to do an EID for this one, but because the submucosa was lifting nicely, we went ahead and removed that with ESD. But this was the histopathological specimen. So that showed a tiniest segment of probable invasion. There was no lymphovascular invasion, but there was lymphoproliferative assessment within the specimen in the muscularis. So this caused a huge debate among 5 of the histopathologists. So 5 GI histopathologists looked at this, and they could not concur what this was. So the reason for that is 2 of those features of tubulovillous adenoma with high-grade dysplasias, 2 said this is equivocal of malignancy, and 1 believed that there was early invasion. And then the case was referred to bowel cancer screening program external assessors, and they came back and said, this is an invasion, but because it was cleared by 1.2 millimeter and without any high-risk features, this was an R0 resection. So fortunately, I got away with it. But did I predict it right? I may not have. Just being honest here, I may not have predicted that. But Just because the submucosa lifted well, I went ahead with ESD. Otherwise, the plan was EID. Probably EID would have been better. That's my hands up. Let's move on to the next slide. This was the EID that we performed. So this was ugly looking rectal lesion, really ugly looking. The whole area looked as though it was a cancer with horns on the surface. Whenever you have polyp with side horns, that is an abnormal, ugly looking, possible deep invasive cancer. This is underwater assessment of the resection. As you can see, some of the areas, just one area right in the center had loss of pit patterns, but the whole area was fine. Again, histopathological assessment said we were R0 resections, and that was because of EID that they got extra depth. Otherwise, if we had gone ahead and ESD'd this, that wouldn't have been a complete resection. The third case, however, when we did the full thickness freehand resection and closed with suture rod, this was the case which again generated a lot of discussions among the pathologists. If you trace the margins here, it has intact muscularis mucosa, but there was vascular invasion there. The yellow arrow shows vascular invasion. Again, if you see that there is deeper invasion, but because of the intact full thickness muscles, then the histopathology conferred that although 3 out of 12 slices had deeper invasion, the overall resection was R0. What I'm trying to, I will skip this video of EID for the sake of the time. What I'm trying to suggest is we may have got away with all the 3 cases. Identical morphology, almost, but we have gotten away with it. Are we ready to put our money on to each one of the cases? No, we are not. I don't think we are there yet. So my take-home messages, ladies and gentlemen, and the chairperson, is optical diagnosis is key in successful outcomes. We need to train our eyes, we need to train our juniors' eyes before we hone our skills. We try and jump to learn ESDs, but we try not to learn or avoid the pit pattern recognition, trying to assess those things in deeper depths. My suggestion is to use the best equipment you have in the unit, whatever it is, use the best equipment, use the best adjuncts you have, whether it is your cap, transparent cap, whether you have stains or you have any other dyes, use the best things that you have. And use optical enhancement techniques, that is zoom techniques, for example, if you have. And again, this is an area that it's a colorectal polyp. Assess it after resection. After resection assessment, underwater assessment gives us so precise evidence. Because when you see a 7-centimeter lesion, you will not be able to assess each one of those areas accurately. When you resect it, you've got a flattened area, you can assess underwater each one of those areas minutely. So please try and do that. So this is again assessment with the stain after resection. I don't like using Lugol's before you do ESDs, not on the same day because it just constricts and causes problems. But when I've marked out the lesion, I try and remove it, and then I use Lugol's to confirm that I've resected everything. So, ladies and gentlemen, last slide. ESD is not a diagnostic discipline with a knife. It is a curative, it is a therapeutic option. I hate the word when people say, can you do diagnostic ESD? There is nothing called as diagnostic ESD. And if you have unsuspected pathologies, if you're not confident in the pathologies, you may have unwanted complications. You need to remember that. And remember to read the polyp after resection. And I will leave the slide here with this kind words of wisdom from my mentor. He always says, patient's benefit is the most important thing. And please do not use this ESD as a tool for self-satisfaction. It is the most important advice that he gave me. So thank you so much. Thank you for listening. I'm happy to take any questions.